In this particular case, it was very funny. If you not ask this case in the properly in the exam, what sort of a rash? They don't say ulcers or something. What sort of a rash it started with? And when you notice it, is it the first time? And you will go back. She will tell yes, and then you will ask, when was that before? 2 years back, doctor. Okay. So what happened at that time? I was having sore throat and something, blah blah blah. She had an infection, and she will give you that. And if you will ask that is and like this partner had it, she will say no. When was it? Who had it? So she will tell you really. She the role play in the exam did say that I had six partners. My second partner, not the first partner, I was doing safe sexual practice. Second partner had this ulcers I noticed, and other partners I use safe sexual practice. I did use condom. So you need to be worried about it. She might have contracted to this recent partner now. Okay, so you will be talking about STI contact tracing in the end of the management, also the education. Going on that, you need to be also be in this physical examination. You will be checking for prom. It is very important because the management will vary on that. Again, how long this has been there. If these eruptions has been there within 72 hours, then we will be giving acyclovir. If it's not, it's and the delivery course has to be explained. So Dr. Andrew will be asked what is happening. Dr. Andrew is not in when
Yeah, I'm
you're
still here.
speaking, but this is the thing. Yeah, this is the thing which you need to ask. Rash. If you don't lead up the point rash as a question, then the role play would not give you. You need to properly ask how many partners you had a sexual contacts. So whole STI question has to be proper in this one. Okay, don't make a mistake in this exam because couple of candidates did and they easily failed that. And again, if any sort of membrane happened, the management is entirely ghost. We will talk about this now. Okay, Dr. Henry will take over there.
Yep. Sorry, where
And
did you
yeah,
get
these
to?
are your differentials. I'm
Which slide are you
the
on now?
history doctor.
You finished that one, or you?
I'm on. I'm just saying these are my differential. I'm going history.
Yeah. Okay. Um, so yeah, history comes down to obviously correct checking that she's at the right stage, calculated correctly, antenatal checkups, antenatal checkups. What does it mean for the pregnancy right now? What symptoms can she expect? Why could this have happened? So we're talking about the stable relationships and everything. And
Doctor,
has
we are
she
in
had
the
this?
first slide.
Sorry. Yeah,
We
sorry,
are
I'm
in the
going to
first
that as
slide.
well. Um, you want to know what symptoms she's experiencing. So, is it a lot of pain? Has she been using any painkillers? How long has she been in that state for? Is there any burning, stabbing, any problems when she does passes a wee or passes a poo? Is it the first time that she's had it? Any fevers or headaches, any lumps and bumps in the body. So if she got any nodes, there might be localized nodes in the groin, vaginal discharges.
And
Hello.
pain management. Yeah, I would like to interrupt a bit. We are actually doing Dr. Entry is doing pain management because she will be passing prom, having ulcers. It's very uncomfortable. So you need to address the pain first. Okay. Yeah, Dr. Entry, you can take over.
And yeah, so what is her main concern in part of this as well, which Rachna just mentioned? Pain would be the most important thing that she's worried about at this stage, and then what does it mean to the pregnancy as well? Um, I think timeline is very important. You know, if you can get a clear, accurate timeline, you can treat it. If it's like, oh, I don't know how long they've been there for, obviously in an exam case, it's difficult to ascertain, but usually they'll give you a clear timeline, and that's what you need to go off on. You want to know about the pregnancy. So is the baby kicking? Can they still feel movements? When was the last antenatal checkup? You can ask about their relationship. Has it been stable? Has she had multiple partners in the past? Has she had other STI, other checks, so Hep C, HIV, CMV, that kind of stuff as well. And has she had any treatments in the past? Could this be a recurrence from a recent infection that she might have had? So those are the kind of things very specific that you want to ask about, especially the genital region as well. Physical examination, you're going to ask about general appearance again. Is the patient well, unwell? Vital signs are important, not a great deal important if they're absolutely well. So you're going to focus yourself on the abdomen and the pelvic region as well. So abdomen, you're going to find about fundal height, tenderness, any rashes in the abdomen, and heart sounds. With the pelvis, obviously, with a chaperone, you're going to inspect, gain consent, then inspect, and you're going to take some, look for any vesicles, where are they, discharges, and any bloods, any other lesions that you can see, and take samples. So viral swabs versus MCS swabs. You're going to look for any lymphadenopathy in that region. And then you're going to talk about basic bedside tests. So you're going to take the blood count, urine for PCR, and you're going to screen for other.
Doctor, one second, doctor, 1 second. Guys, if you're thinking of all these lesions, what are the investigations you will be, apart from what we mentioned, what are the investigations you're going to think about it as well? Provided, yes, I spoke about if it's acute urinary retention, we will do suprapubic aspiration. But I want to know what are the investigation you will think in between? Someone having a lesion like this. Yes, because this is part of very important. I want to do some of the things which I need to do in this case. What are the investigation? I don't want like us to think about it. We did their exam, so yours. Apart from PCR. Quickly, guys, don't face some. Okay, so here we will be doing, like coming back to it, STI screenings for this one. And while we are actually collecting it, you will be asking examiner, I will be taking a swab, like local vaginal swab to actually rule out PCR examination. We need to specify it because that's what also you would be taking STI screening. And again, nitrogen or fibronectin test has to be done immediately, whether she's having a premature rupture of membrane. The classical history they give in this case is a herpes that's giving serous discharge. Serous discharge, it could be premature rupture of membrane. It could be present again in the herpetic. Okay, so you do need to talk about it. Again, talking about, as I mentioned, it's a lower immunity as well. So we need to be talking about ruling out full blood examination to find out whether she has a lower immunity because of any. All right. So yeah, sorry, doctor, continue. And yes, see, I have actually mentioned nitrogen testing coming up for the PP prom, and that would be the critical error. That might be, she might have a lesion around her vagina, and what happens is, so what we are avoiding in throughout this case is ascending inside her womb, inside her urethra, and inside her. Simple as that, because that means we don't want that. And then otherwise, when she will deliver, very likely the child will be born with a congenital anomaly. And again, those infectious causes. So again, when we explaining conditional, which is herpes, what is recurrent herpes looks like, and what virus causes that, you have to mention. Then if it's a first episode, you need to explain her first episode treated with by acyclovir. It can happen again because the virus stays in the dermatome, okay? And it comes back when you have a lower immunity. Following by that, you need to what happens to the baby. Dr. Andrew.
Yeah.
Dr. Andrew.
So yeah. I'm listening. Yeah. So with the investigations, the other thing is you're going to offer to test the partner as well, is part of the screening process.
Yeah, that's
And the
important.
other thing is you're going to gain consent, obviously, from the patient to test, but there is one specific consent that you need to think about, which is HIV testing. Now, this would have been done as part of her um, antenatal screening. But if you're going to repeat it for whatever reason, you need to have specific consent for HIV as opposed to consent for other things as well. So that's something you need to be mindful of. That on patients you can sometimes do a lot of the other investigations, but HIV you actually need specific consent from the patient, and testing the partner is also important. But mindful that just because someone has an infection, you can't really pin it down to who gave it to who kind of thing. Don't try to get into that kind of stuff. Management really comes down to management of genital herpes. This is what it is. Usually, it's most of your cases going to be genital herpes, or they're going to give you some other kind of warts. You're going to explain to the patient what it is. It's obviously a sexually transmitted disease or infection. There are two types, 1 and 2, and that both areas can be found in the genital area. Once you have the virus, it kind of stays in your body for life. You may get one episode, or you get maybe multiple episodes over your life, and then the next thing is her concerns. What are your concerns for? You can, instead of telling the person sometimes what your role player is in front of you, you can ask them, what are your concerns? Are you, they might tell you, okay, I'm concerned about this pregnancy. If they don't tell you that, then you need to touch on that point. Look, have you thought about what effect could have had on your pregnancy? These are the things you can think about. So illness in pregnancy can become activated again, causing an ulcer and itching, which can happen during pregnancy. Apart from both of them going to have the screening, what does it mean for the baby? So if the baby is delivered, genital herpes can be treated safely during pregnancy, but she can have a vaginal birth, but there are some people who will recommend that she may not have a vaginal birth. So you got to address that as well. She might be only wanting a vaginal birth. So recurrent episodes do not affect the pregnancy itself, do not affect the baby. Obviously, the baby's in the womb. There's a barrier there. But if you get genital herpes for the first time after you become pregnant, this could be more serious. And if it's in the first 3 months of the pregnancy, as opposed to there is a small chance of miscarriage. And if you get it in the later, so within 6 weeks of birth, there will not be time enough for your immune system to provide enough protection. If you then give birth vaginally, there's a small chance, 40% chance, actually not a small chance, of passing the virus to the baby. So that is something that is the most important thing that you need to tell her, that she might not be able to have a vaginal birth if she's expecting that, and that she might need to go down a cesarean pathway. The other thing is you need to describe why there's an issue. So if the baby catches the virus at birth, obviously it's called neonatal herpes, and it can affect the baby's skin and eyes. It can cause an infection into the brain and other body organs, and the child can become quite seriously ill and die in the first few days of life as well, or after birth. And that's what is very important to tell her. What treatment can you give her? You're obviously going to give her antiviral tablets, so acyclovir, and obviously the first 24 hours to 72 hours is the most important, as we all know. She may be admitted to a hospital if it's actually very difficult for her to pass urine or do open her bowels. You can get frequent episodes, so she could possibly have another episode during this pregnancy. Sometimes they may give her a longer period of treatment, and the aim of the treatment is to help reduce the length and the severity of her symptoms. You can give supportive treatments, so topical lignocaine for pain relief or topical acyclovir. We know that it is safe during pregnancy and breastfeeding, acyclovir. So if she does give birth, if she does need to use it after birth as well, it is safe. And this is where the cesarean bit comes in that we were talking about before. So if you were infected before she became pregnant, obviously not. If you develop it between 6 weeks before delivery, then a cesarean is probably more apt. And you can still have a vaginal birth as long as the infection's been cleared. There's a counseling aspect to this as well. So obviously the spread of infection can be prevented by avoiding sexual contact during the activity of lesions. So that's something that she needs to be mindful of. Obviously wearing protection, so condoms, is important. And what presentations a baby might come with are skin, eye, mouth disease, so localized to the central nervous system, so meningoencephalitis, and can have other non-specific symptoms as well. I'll pass it on to Rachna as well, just to talk about. Rachna, go ahead.
Okay, so the role play these days, those play these days are asking if we don't tell the name of complication of herpes. They ask you the name. They might not ask you the complete detail. Maybe you. So I have mentioned here in the slides neonatal herpes, and we do have to talk about what is exactly happening if we don't take care of if she's having an active lesion. Okay, so do make sure you even lithium in pregnancy or the complication of any medicines to the baby. They ask in a detail. They will give you a pause. Doctor, tell me what happens. So specify that. If you do not specify the name of the cause, same thing which is transferring from mother, if you do not name that in your exam, it's a critical error. Okay. Another thing which I want to tell, the course of management about cesarean section and normal delivery, again, depends on the active lesion. Also, how much of the lesions are being in, okay? So if there are many, then you would be preferred by the obstetrician. It would best that you leave everything on the specialist, type of normal delivery or specialist review in this case. So rather than explaining the whole as well, if you're running out of a time, that's just my brief idea. That's how I did in my exam. I passed my station by saying that, okay, everything specialist will leave it. I leave it to specialist. He decides the normal delivery and he decides the cesarean section. I'm good to go to tell you what happened to the baby if we don't take care of it. That's the only main. Okay, that's the only thing. Rest, what Dr. Andrea mentioned, the local care, safe sexual practice, STI screening, everything rest follows the same. Yes, I have to explain everything if you don't. But if you're running out of time, that's my tip. Please leave it to specialist. Normal delivery, cesarean section, he will take care. I'm not obstetrician. I'm done. Okay. So, is there any difficulty understanding of any of these? What Dr. Andrea, two people are switching over. But is there any difficulty you understanding this case? Any doubts about this case? Ask us right now rather than asking later on. I will. Any questions? No question. Some question.
Okay, you want to move on to the next one?
Response. None of them giving response.
That's okay.
Any question, guys? Or it's confusing, or you're finding it hard?
Okay, so the next case, case 3. So a middle-aged female comes to you. You're in a GP setting, complaining of hoarseness of voice. You got a very short period to take history here. They really want you to get over the physical examinations and arrange an investigation, diagnosis, and the management. differentials. Read your STEM twice, 3 times.
Keeping in mind,
most of your answers are in the STEM, or leading issues are in the STEM that they want you to discuss. As to what it is, most likely is what it could be. So start off with the most important life-threatening things that we're talking about, then talk about important cases, common cases, and then talk about other stuff. So voice abuse is good, but think about the most dangerous stuff.
And keeping in mind, if it's 3 minutes, don't go beyond 3 minutes. There are cases, and physical examination, that means the examiner wants a detailed physical examination in particular stage. There are different tasks there in the exams. Yeah.
So again, when you're thinking about this, you can think about what are the most life-threatening things, but also think about anatomically, where is it coming from? Is it actually hoarseness of voice? So hoarseness of voice, if it's a true hoarseness of voice, is coming from the vocal cords or in the laryngeal area. Could there be something in the mouth, orally, in the oral cavity? So the tongue, the teeth, a lump. Could it be a large tonsil that's giving her voice issues? Could there be angioedema? Could there be those kind of things? So you need to think a little bit streamlined as well. Yep, thyroid, cancers, yep. Anything else that could cause a weakness?
She's a school teacher. Yes. That's correct. What is overused? What we see overused? Yeah, vocal cord. Is there anything anyone to add apart from those differential? Ikra, Max is not writing today itself. Sunan, Augustine, Rainy. That's good. Good. We should be thinking about that too. Okay, I'll give you both of you credit. Dr. Andrew, are you happy?
Yeah, I think these are good answers. I like the GORD as well. I think reflux is something you should think about, which is not on our list here, but that's a very good answer, I think. Yeah, recurrent laryngeal nerve injury. I think that's a good thing. She could have had some kind of operation recently or in the past, and now seeing the effects of this. No, that's good.
Okay. So let me just go into the case now, and Dr. Andrew will take over. The thing is, what this cases came in exam last couple of years. Was coming is an overuse of voice or hoarseness of. Now I brought this. I've been promising bringing this case again because it's most of the time it's overuse of voice. It in Karen noted. So one time they had changed into thyroid cancer. One time to the breast cancer metastasis, and one time they actually changed it to lung. This case is coming around the cancer. Now the thing is that she has been actually had the lung cancer, but she was not knowing it. Events here will be actually talking about lymph nodes and weight loss, which is usually people ask. But having said that, you will be also be looking for significant weight loss. If you do not put up a stress on the significant weight loss, you would not. So you need to know, well, you need to ask this patient how much is the weight she has lost. She would have lost 6 kilos in, okay? She will be feeling that she's been skinnier. She will be feeling she's tired, and then you will be asking a little bit of a tired question. Talking about when you will ask in a detail of shortness of breath, if it's been there, she will be telling you in one of the part of the history. She will give you chronic history of smoking with overuse of voice sort of a history. So examiners are actually playing with your head because they know that you're doing Karen node a lot. So you will be talking about hoarseness of voice only. But this is my mom died due to cancer and she had a hoarseness of voice. Okay, and it's not always a lymph node will be need to be done taking as a classical history of that. Okay, putting up a stress on that, you do need to rule out thyroid like hypothyroidism, thyrotoxic, and then cancer in the thyroid. You need to, and again, overuse. So you need to be systematically asking all those questions. I'm not going into that. Dr. Andrew will cover this part. Having said that, like she would not be stopping the like cancer. I mean, she would not be stopping smoking because she is quite addicted to it. Okay. And end of the day, you will be doing a proper physical examination, which are but you do need to rule out breast cancer history. You do need to rule out again tiredness a little bit as a cluster. You do need to rule out ENT as a cause. Also, you do need to rule out. Keeping in mind, people with the cancer have a recurrent flu because immunity goes down. If you're not suspecting that in your history, it's a critical error again. You might not be thinking as a big. So, yeah, Dr. Andrew.
Yeah, so those are good answers. Again, think about it more in an organized fashion. What do you not want to miss? Hoarseness of voice doesn't always mean cancer, so be mindful of that. So yeah, talk about when did it start? What is actually happening? Is it gradually getting worse? Is it getting worse suddenly? Is it at some time of the day? Is she okay in the morning? Is it worse at night, or does she start out with a horse in the morning and it's okay by nighttime? Has she been exposed to any irritants, pollutions, or anything else? We already know that she's a teacher, so she obviously uses her voice a lot more than usual. But does she do anything specific? Like, does she sing? Or did she go out and be at a party recently? Has she been unwell with any flu-like symptoms? Could it just be a laryngitis? Or has she had something similar in the past? Are there any sore throat? Is it painful, non-painful hoarseness? There's two differentials to make there. And does she find that it gets worse when she goes to work and it's better when she's at home resting? Are there any other sort of symptoms with it? So if you're thinking hypothyroid or thyroid issues, cold versus heat, that kind of stuff as well, constipation, fatigue, any lump in the throats that you want to ask them. Has she been feeling that there's been a slow growing lump there? Has she been having any other issues? So things like, is it giving her trouble breathing or anything else like that? Change in appetite, weight loss is important. Cough, any sputum production, any blood in sputum. Does she have a problem swallowing with any of this? So could there be a mass that's actually giving her problems? And does she have any lumps anywhere else? Could it already metastasize? Does she have lumps in her armpits, in the neck, cervical chain, anywhere else? Are there any associated symptoms like we talked about, allergic rhinitis, postnasal drip, family history of any malignancy? Has she had any neurological diseases in the past? Any thyroid or neck surgery in the past? So anything that could possibly give you or lead in. What you're really looking what you're doing by asking these questions are looking for lead-ins into where is this coming from.